I was trying to do the math on the way in today.
So, yeah.
If you eat, say, 3 meals a day, maybe a snack, over 60 years or so, you are performing the act of swallowing nearly 1,000,000 times.
That sounds about right. And for the vast majority of those 1,000,000 times, you are completely checked out.
Totally.
You don't think about the muscle coordination, the nerves, the valves. It is the ultimate autopilot function.
Until it isn't.
Until it isn't.
And that is the nightmare scenario we are unpacking today. We've got a stack of notes here from a medical lecture, specifically a video transcript focusing on esophageal pathology.
Luckily.
And the mission for this deep dive is to look at what happens when that autopilot system just hits a physical wall.
A wall that, interestingly enough, your body builds itself.
Which is just terrifying. We're talking about a condition with a great name, Schatzki's ring. And honestly, reading this felt less like biology and more like a plumbing manual.
It really is.
We're dealing with pipes, blockages, pressure, and some surprisingly aggressive tools to fix it.
It really is biological plumbing. The medical term we're going to be throwing around is dysphagia.
Dysphagia.
Which is just the clinical way of saying difficulty swallowing. But as we'll see in this case study, dysphagia is really just the smoke signal. The fire is something structural deep inside the chest.
So let's set the scene. The source material centers on a specific patient case, a 65-year-old woman.
Mm-hmm.
And her story starts with something pretty mundane, a chicken sandwich.
The infamous chicken sandwich. It's actually a very common culprit in these cases.
Is it really?
Oh, yeah. Dry meat, bread. It's the perfect bolus to get stuck.
Right. But before we even get to the sandwich incident, the notes mentioned she'd been struggling for a while. She reported choking spells for a couple of years.
Yeah.
Now, when I hear choking, I'm thinking hands to the throat, Heimlich maneuver, life or death stuff. Is that what she was dealing with?
That's a common misconception. In this context, choking spell usually refers to that sensation of food just hanging up. It's not necessarily cutting off her air. She can breathe. But the food isn't moving. It's stuck in transit.
I see.
And what's fascinating about the human body is how we adapt. The source implies she lived with this for years. She probably learned to take smaller bites, chew longer, maybe drink water after every swallow to force things down.
You compensate.
You compensate, exactly. We call that compensation.
It's like the boiling frog effect, but for your own esophagus.
Precisely. You don't realize the pipe is narrowing until you encounter a bolus. That's the ball of chewed food that simply refuses to fit.
And that brings us to the inciting incident, the chicken sandwich. She eats it, and it gets properly stuck.
And the source makes a really important distinction here right off the bat. It's vital for figuring out where the problem is.
Okay.
There are two main types of swallowing failure.
Yeah, I flagged this because I'm a bit of a hypochondriac, so I need to know which one I should be worried about.
Well, think about the mechanism. Phase 1 is the transfer. You chew, your tongue moves the food back, and you initiate the swallow. If you choke there, if you cough, or it goes up your nose, or it just won't go down the hatch, that is oropharyngeal dysphagia.
Okay, so that's the launch sequence failing.
That's the perfect way to put it. It's usually neurological or muscular. Think stroke patients or Parkinson's.
Got it.
But our patient, her launch sequence is fine. She chews, she swallows, the food leaves the mouth, everything seems normal for a second.
And
then a few seconds later, it halts in the chest. That is esophageal dysphagia.
It's strictly a transport issue.
It's a traffic jam in the tunnel. And in her case, it wasn't a muscle spasm or a nerve issue. It was a physical barricade.
That is where Schatzki's ring comes into play.
Exactly.
So let's visualize this ring, because the description in the transcript is vivid. I don't think I'll ever forget the color descriptions.
It is vivid, but it's medically necessary to understand it. To understand the ring, you have to understand the landscape.
Right.
The esophagus is a tube that runs down to the stomach, but it's not just one long uniform pipe. It's lined with different types of, let's call it skin or mucosa.
And there's a border where the tube meets the stomach.
The squamous-columnar junction.
Which is a mouthful in itself.
It is. But structurally, it's the meeting point of two worlds. The esophagus is lined with squamous epithelium. The source describes this as pink.
Pink.
Think of the inside of your cheek, pale, smooth, durable.
Okay, pink squamous. Got it.
Then, as you cross that border into the stomach side, the lining changes to columnar epithelium. And the source describes this as
leafy red. It sounds like a menu item, but I get the picture. It's darker, richer tissue.
It's very distinct. Now, in a normal anatomy, that transition line, that Z-line, is smooth, it's flush.
Yeah.
But in our patient, and in anyone with Schatzki's ring, that junction has Well, it's gone rogue.
It thickens.
It doesn't just thicken, it
Yeah.
protrudes. It forms a circumferential ridge.
Oh.
Imagine a washer inside a pipe, or a little shelf growing out from the wall all the way around the inside.
And this shelf is made of what? Is it scar tissue?
It's mucosal tissue. The lining itself is folding inward. The source touches on this connection to a hiatal hernia. That's where the stomach pushes up slightly through the diaphragm. When that happens, this junction point gets exposed to more turbulence, maybe some acid reflux.
Okay, so it's a reaction.
The theory is that this ring might be a defensive reaction, the body building a little dam. But the problem is, the dam gets too high.
And cuts off the flow of traffic.
And this is where we get to the real insight of this lecture, the key takeaway. It's not just about having the ring. Lots of people might have a slight ridge and never know it.
Mm-hmm.
It all comes down to a specific mathematical threshold.
The magic number. I have it highlighted here. 13 millimeters.
13 millimeters, that is the tipping point. The source states it very clearly. If the diameter of that ring tightens to less than 13 millimeters, you will have symptoms.
Let's put that in perspective. A U.S. dime is what, about 17 or 18 millimeters?
About that, yeah.
So we are talking about a hole significantly smaller than a dime.
It's a very, very tight squeeze.
And you're trying to push a chunk of chicken sandwich through that?
Exactly. A well-chewed bolus of meat might be 15 or 16 millimeters wide. If your ring is 12 millimeters, physics takes over. It starts. That's the food bolus obstruction.
It's just fascinating that the margin for error is that small. If the ring was, say, 15 millimeters, she might have been fine.
The source actually mentions that. If the lumen is wider than 13, patients are often asymptomatic, or maybe they have very rare episodes. But once you cross that line,
Sub 13.
once you go sub 13, dysphagia becomes almost guaranteed. It's a mechanical certainty.
So back to our patient. She's had these spells. The chicken sandwich incident finally scares her enough to get an endoscopy. The doctor puts a camera down there, sees this pink and beefy red ring narrowing the tunnel.
Diagnosis confirmed.
Now we have to fix it.
Right.
And this is the part where I expected some high-tech, delicate laser surgery. Or a pill that dissolves the tissue.
Yep.
But the source uses a word that honestly made me wince. Rupture.
It is aggressive language, isn't it?
The doctor says, when you notice a Schatzki's ring, you need to rupture that ring. Not stretch, not massage, rupture.
It reflects the nature of the tissue. This isn't a muscle spasm you can just relax with medication. It's a fibrous, fixed ring of tissue. It has structural integrity.
So you have to break it.
To widen the pipe, you have to physically break that structure. You have to tear the ring.
That just sounds risky. I mean, you're tearing tissue inside someone's chest. Is there a danger of punching a hole right through the esophagus?
That's always the risk with esophageal procedures perforation. But that's why the tools are so specific. You're not just poking at it blindly.
Yep.
You're applying radial force outward pressure to split the ring without tearing the underlying muscle wall. You want to snap the washer, not break the pipe.
Okay, that's a helpful distinction. Snap the washer, save the pipe. So what's the crowbar of choice here? The source lists a few options.
The gold standard, the one the lecturer emphasizes as the best option, is the bougie dilator.
Bougie. I feel like we need to address the name. It sounds like a scented candle or a fancy brunch spot.
It does, but the reality is much more utilitarian. A bougie, in medical terms, is just a cylindrical instrument used to dilate a passage. Think of it like a long, flexible, tapered rod.
And the size matters here, right?
Mhm.
We talked about the 13 millimeter problem. What's the solution size?
The source specifies a large caliber dilator, so we're looking for something in the 18 to 20 millimeter range.
So you're going from under 13 to almost 20. That is a massive expansion.
It is. That's almost doubling the cross-section area. And that's the goal. You want to overcorrect. You want to ensure that channel is wide enough that no future chicken sandwich stands a chance.
So walk me through the actual move. How do they get this rod down there safely?
It's a guided missile approach. The source describes passing a wire first.
Okay.
So under endoscopic guidance, they thread a guide wire down the throat, through that tiny hole in the ring, and into the stomach. That wire is your safety rail.
So you've got a line in place.
Then you take the bougie dilator, which has a hollow channel in the middle, and you thread it over the wire. You just push it down. The tapered tip enters the ring, and as the wider part of the shaft follows,
It exerts that force.
it exerts that radial force.
And pop.
Effectively, yes. The source says, as the bougie goes down, it ruptures the Schatzki's ring. It forces the tissue to give way. It's purely mechanical. You're forcing a 20 millimeter object through a 12 millimeter hole. Something has to break.
Wow. I can see why the patient needs to be sedated for this. It sounds incredibly uncomfortable.
Oh, absolutely. But the relief is immediate. You're restoring flow.
Now, the transcript does mention alternatives. The boozy is the favorite. But there were two other methods. One involved a balloon.
Yes, the balloon dilator. It's a similar principal radial force, but a different delivery system.
Right.
Instead of pushing a solid wedge through, you slide a deflated balloon into the center of the ring. Once it's positioned, you inflate it with liquid to a specific pressure and diameter.
So it expands from the inside out.
Exactly. It blows up until it hits that 18 or 20 millimeter size and the ring snaps.
And then there's the third option, the forceps method. This one just sounded tedious.
It's definitely the more manual approach. The source mentions using jumbo biopsy forceps,
Jumbo forceps.
basically large tweezers. The technique here isn't about stretching or bursting. It's about removal.
You're taking bites out of it.
You literally take bites out of the ring. You nip away at the tissue bite by bite at the 12 o'clock position, the 3 o'clock, 6 o'clock, and so on.
Like taking bites out of a cookie to make the hole bigger.
Or digging a tunnel with a shovel.
Mm.
You break the integrity of the ring by removing sections of it. Once you've taken enough bites, the ring falls apart and the opening is wider.
It seems like it would take so much longer.
It likely would. It's probably reserved for specific cases,
Right.
but it highlights that there's more than one way to, skin a cat, or in this case, rupture a ring.
I just want to circle back to the patient experience.
Yeah.
Because we're talking about these violent-sounding fixes, rupture, tear, bite.
Yeah.
But for this 65-year-old woman, this is a game changer, isn't it?
It's transformational. Think about the anxiety she must have felt every time she sat down to eat. Will this bite be the one? Do I have enough water? That stress creates a negative feedback loop. You stop enjoying food.
You avoid social meals.
You avoid social meals, and suddenly you wake up from sedation, your throat is a little sore, but the pipe is open.
The pipe is open.
20 millimeters of clearance. She can eat a steak, she can eat a chicken sandwich without fear. It's a massive quality of life improvement.
It's amazing how we treat the body with such reverence, like it's this mystical temple. But sometimes you really just need a plumber.
It's so true. At the microscopic level, it's chemistry, but at the organ level, it's often just mechanics and hydraulics.
Pressures, valves, and tube diameters.
Exactly. Schatzki's ring is a perfect example of a mechanical failure requiring a mechanical solution.
Before we wrap up, there was one little nugget at the end of the source material that just, it gave me pause. A bit of a cliffhanger.
Ah, yes. The ominous what if.
The lecturer shows an image of a patient who currently has a chicken sandwich stuck. A full blockage.
It's there right now.
The food is there right now. And he says, quote, "In this case, you need to figure out how to remove that. We will talk about it in another session."
It stops you in your tracks, doesn't it? Because everything we just discussed, the bougie, the balloon, that is maintenance. That is what you do when the esophagus is empty.
Right. You can't ram a 20-millimeter rod down there if there's a chunk of chicken blocking the way.
No. You'd push the food into the lungs or rupture the esophagus for real.
Oh, my God.
An active food bolus obstruction is an emergency. The patient is drooling because they can't even swallow their own saliva. They are in real distress.
So what do they do? Since the source didn't tell us, I have to know.
Well, without going too far outside our source, the logic is you have to clear the obstruction first. Sometimes they use drugs to relax the smooth muscle, hoping the food drops on its own.
If that doesn't work,
If that fails, they have to go in with a scope, either pull the food out piece by piece, or carefully push it into the stomach.
that sounds like an absolute nightmare.
It is. And that's why the preventative fix the ring rupture is so vital. You never want to get to that point of total blockage.
It really drives home the fragility of the whole system. We just take it for granted. Chew, swallow, gone. But it relies on this seamless transition of tissues, this perfect muscular wave, and crucially, a gap wider than 13 millimeters.
It's a system of tolerances, and when you lose those tolerances, the system crashes.
So what's the big takeaway here for our listener, other than, chew your food like your life depends on it?
Well, that is a good takeaway, but I think the deeper insight is about listening to the whispers of your body. This woman had choking spells for years. She ignored them or adapted to them.
She normalized the dysfunction.
Exactly. If you have trouble swallowing solid food, even if it's just once in a while, that is not normal. That is data. It's a signal that the plumbing is changing. It might be a Schatzki's ring. It might be something else. But ignoring it until the chicken sandwich incident is playing a dangerous game.
It's the difference between a scheduled maintenance visit and an emergency tow truck.
Perfect analogy. Get the maintenance, check the pipes.
And maybe, just maybe, look at your lunch a little differently today. That bolus has a journey to make.
It certainly does.
This has been a fascinating look into the mechanics of the throat. Who knew pink and beefy red tissues could cause so much drama?
The body is full of surprises.
Thanks for guiding us through the plumbing, literally.
My pleasure.
And for everyone listening, chew well, stay safe, and we'll see you on the next deep dive.
Take care.